We are so glad to have you guys with us today. This is part of a larger series that the Centers of Excellence are able to do and put forth each month. For those that are brand new and may not even know what the Centers of Excellence are, I'll do a brief introduction to orient us to what we're here to do today. The Centers of Excellence are a network across the states. We are at the UT Memphis, at Vanderbilt, UT Knoxville. We're in the Southeast COE in Chattanooga and Northeast COE with ETSU, and really exists to provide a network of support to kids who are in custody and at risk of custody and to the child welfare system. We provide consultations, psychological evaluations, and really work on disseminating evidence-based treatments so that our kids in custody, when they go to providers, have evidence-based treatments available to them. As a part of this, we also are able to bring in this monthly series that's focused on topics pertaining to children in families and child welfare, and are so excited today to have Dr. Molnar with us to talk a bit about neurobehavioral functioning of children prenatally exposed to substances, with an emphasis today on neonatal abstinence syndrome. To introduce Dr. Molnar here, he is a child and adolescent psychologist with a specialization in pediatric neuropsychology here at Vanderbilt University Medical Center. He's been here for quite a while and runs the kind of assessment clinic right now over with our child and adolescent outpatient clinic, providing neuropsychological evaluations, training students as well, and being able to offer these services. He also does a lot of other things. He's involved in quite a bit of research on many different projects, including youth with Tourette syndrome and delirium and preschoolers who've been prenatally exposed to substances. Where I think with Dr. Molnar, what stands out to me, we did a consultation a while ago with a foster parent who had a very complex little 4-year-old boy that Dr. Molnar had done an evaluation with. And what she described was just the amount of warmth and expertise that he brought in, that she felt like finally somebody was understanding her and understanding that child, bringing all of these complex pieces together to be able to offer kind of what's the path forward and what do we need to do in a way that really stands out, really pairing this piece of, I have the science and the research and the training and the expertise and neuropsych and all of this, but also able to be with clients in a way that they are seen and heard and valued. That is just a strength he continues to bring to the department and to Middle Tennessee as one of the only, if not the only, neuropsychological providing for TennCare in Middle Tennessee here. So I will hand this over to Dr. Molnar to get us started. First, if you want to, make sure to do some introductions in the chat. Let us know who you are and what your role is, so we can have some context here of who's with us today and what might have you interested in the talk today. As we're going through, feel free to drop questions in, and as they're coming to you or you have them as you go. Dr. Molnar is going to take some breaks intermittently to address those questions and check in with us. So feel free to get chats and conversations and questions going in here, but we'd love to also see you introduce yourselves in the chats as we get started. So Dr. Molnar, I'll hand it over to you.
Sure. Good afternoon, everyone. And so I am with Vanderbilt, but I am coming to you this afternoon from Johnson City, Tennessee, where I visit often. So it's a beautiful day here. This is a very generous lunch and learn series. So I hope everyone is able to find something to eat, settle in, but there's also a huge learning component here as well. So I love the idea of kind of doing a roll call. If you will please take the time to kind of drop your name, your occupation, and maybe your affiliation in the chat so we can get to know one another and who's on the call. As Dr. Smith noted, the chat will be open and we'll take a couple kind of planned pauses throughout just to kind of open up the dialogue. I'm also very interested in knowing what others are doing in this area of practice, including broadly with children prenatally exposed to substances. And then towards the end of the talk, we'll kind of focus more specifically on neonatal abstinence syndrome. So thank you all for having me, and to Chris and Caleb, Karen and Kevin for arranging this. And I'm going to start just kind of showing just a general outline. So this is where I'd like to kind of go this afternoon. I want to just do a couple slides just on embryonic and fetal development. I think it's important just to reset our brains a little bit on this beautiful Friday afternoon, just about why this is important and how early these processes happen in utero. And then we'll kind of break down some more specifics about what we know with certain recreational substances, and their associations with neurocognitive development. I'd like to present sort of a case example. I want to talk about environmental toxicants, as they also are relevant. And then we'll focus more on NAS, which also now is known as NOWS, for more specifically opioid induced challenges. And then we'll end with some discussions about early interventions. So if we think back to maybe college or other textbooks, you may have seen this image somewhere along the line, but very early on, we're talking like within 10 hours of conception and so forth, there's a lot of processes that are already happening at like the cellular level. And even from like a neurobiological lens, the neural tube itself is already starting to develop, as sort of the core of the central nervous system. There are many kind of cellular processes that are going on at multiple times. So there's new cell birth, there's cell migration, there's different cells taking on different roles and differentiation stages. There's cell maturation, so the growth of them, as well as the beginning stages of what we'd call like synaptogenesis. And so the neural tube then becomes the center of like the development of brain and spinal cord very early on, even within the first 3 weeks. This neural tube, which I've highlighted in this diagram here, you'll see in the red, is then responsible for the expansion of all these other, the top areas you'll see pink, orange, green brain areas, and then in the yellow, the spinal cord. And you'll see that over the course of fetal development, that neural tube goes from being kind of a singular entity all the way to the far right of the screen, where you see the differentiation in colors, to more separate brain systems that we commonly refer to as things like the thalamus or the cerebellum or the neocortex, which would involve like the frontal lobes and the parietal lobes and the temporal lobes and those kind of things. So this whole process is taking the course throughout the in utero the process. I also appreciate this image. It's an old one from textbooks. But if I can explain it real quickly, at the very top, you'll see numbers, and those represent weeks. All the way on the far left would be like 1, 2, 3. All the way on the far right, you see like 16, and then 20 to 36 and 38 and so forth. You'll also see just below that, some of the early cellular processes all the way to fetal development. And then below that, you'll see bar graphs. So you'll see red and then yellow. And the red represents critical periods of development for different systems. So the very first bar graph you'll see going horizontally is the central nervous system. And so really things that disrupt that formation between weeks 3 through 16 are known to be significant risk factors to the fetus. And you'll see that differentiation for the heart, for the upper limbs, the eyes, the lower limbs, the teeth, the palate, ear, and so forth. Again, with the point that some of these risk factors that come external of the fetus itself can really have significant and profound effects very early on in the stages of development. So the takeaway points from that would be that, this develops in stages. There are certain cellular stages that are programmed that, originate in this very early age ventricular wall. There's initially a large abundance of cells, and then they specialize over time. And most importantly, the message would be that growth is susceptible to genetic or environmental risk factors, especially in that first trimester. Those would be key points I would want you to kind of take away from this, brief review. If we look a little bit more specifically at things that might be driving this, I think we can start by thinking about recreational substances, right? And so one of the more common ones that has been studied would be alcohol. And we know this to be a teratogen that passes through the placental barrier and infects the size and structure of different brain regions. So when scientists have, studied children who had been prenatally exposed to alcohol, they can see differences in frontal, temporal, and parietal lobe development. And some even scientists have pinned it down to where these sensitive periods are most profound at like the first and second trimesters, where the external substance is really interfering with these cell migration processes, with the proliferation, with the organization of brain cells. And by the third trimester, when the brain is kind of more developing as we would commonly understand it, in our terms, it can be associated with damage to specific parts like the cerebellum, the hippocampus, and the prefrontal cortices. We know that alcohol also affects not only the structural, but also the neurochemical processes. So there's a decreased transmission of the acetylcholine systems, which are important for neurotransmitter uh, productions. And then you may recognize from your own clinical and field work that there are structural differences as well. So the image on the right kind of shows a child, but you'll see kind of two sizes of a child's head, the larger being sort of more typical, the smaller being more atypical, and what we call microcephaly. So kind of a smaller circumference of the head itself. And so not only can you see that physically, but when you look at whole brains and imaging, you can see cell migrational anomalies. So these would be called like heterotopias, where early on in fetal development, there was actually a disruption in how those cells grew across, different systems. You can see specific abnormalities in areas like the corpus callosum. You can see reduced frontal lobe system size, cerebellar size. You can see effects related to the basal ganglia and also to the hippocampal symmetry, which is important for memory systems. Clinically, we, in the field work, describe this as like a fetal alcohol spectrum disorder, right? So this is kind of an umbrella term that's used. It's fairly non-diagnostic. It can describe a range of deficits. So it can be used to describe something representing cardiofacial abnormalities, cardiovascular, skeletal, even neurological. In my teaching with students and so forth, one of the things I emphasize it is, and why I put it in bold, it's the leading cause of preventable intellectual disabilities, and that is alcohol exposure prenatally, because we know that there is a high association between that exposure and intellectual disabilities for youth. If we think more diagnostically, then away from the FASD classification, you can appreciate terms such as fetal alcohol syndrome, which I imagine we can all kind of nod our head at a little bit as we've heard that terminology. Fetal alcohol effects, alcohol-related birth defects, and then alcohol-related neurodevelopmental disorders. I would say clinically, in the hospital systems, and with the research, I more commonly see the term fetal alcohol syndrome described. We know that exposure is kind of the threshold for the severity of the presentation, right? So it's been reported by the CDC that 14% of pregnant individuals report drinking in the past 30 days. 5% report binge drinking in the past 30 days. And it's also on the government websites that rates had increased from 2011, to 2018, quite substantially. Even though some of those percentages just look just like a little adjustment, they're notable, right? And that some of these specific risk factors for substance use would commonly be associated with such things as mental health distress in the caregiver, as well as just having reduced access to healthcare and providers. The incidence of, if we're thinking about FAS specifically, so not the larger undiagnostic terminology, but FAS specifically as a diagnosis, the incidence is around 9 to 1,000 births in the United States. And it tends to exist much higher in African American and Native American populations, and of course is confounded by factors such as socioeconomic status. Other things can include mental health issues, social isolation, a history of abuse, including childhood sexual abuse. So parental mental health certainly has an association then to the prevalence and the incidence of it. Some things that help differentiate, the severity, right? So is there a mild case of fetal alcohol syndrome versus a more pronounced case? Sure. So some of that has to do with like the blood alcohol concentration levels, right? So is there no risk, unknown risk, some risk, high risk? What's the pattern of exposure? Was it intermittent? Was it more chronic? What was the timing of the exposure? So was it more notable kind of very early on? If you think about those previous pictures I showed you in the first and second trimesters. And then other factors exist, such as polysubstance use, right? In our clinical work, we appreciate that these things usually don't happen in isolation, correct? And so having multiple substances is often sometimes the social circumstance we're working with clinically. Again, maternal mental health challenges, having inadequate nutrition, and being in stressful environments. So these are all factors that could play into FAS severity and be associated with the incidence itself. If we look at FAS diagnostic criteria, we know that there needs to be indication of growth deficiency. There is commonly kind of distinct craniofacial features. So you might see more of like a flat mid-face, a short upturned nose, a smooth long philtrum, a thin vermilion area. These are well validated and known from physical and other sciences. You can also see indication of central nervous system dysfunction. So some of the structural abnormalities, so that picture I previously showed you with the child that kind of had more of the typical size head versus the smaller or microcephalic head. You can see smaller cerebellar areas. There can also be neurological conditions that coexist, such as seizure disorders or other functional impairments, such as the cognitive disorders, which in this population would commonly be things such as intellectual disability. One thing that's a challenge is there is currently no reliable biomarker to assess the degree of prenatal alcohol exposure, right? And that has both clinical and research implications, right? And there's a number of reasons why, sure. One, it's not often detectable and it fluctuates, that detectability fluctuates. And then sometimes there's such a strong stigma around it that people will underreport it. We also see that in research where people just can't remember, or it's not known, or the child is no longer in that care environment. And so there's a lot of unknown factors. So this would just be an image representing some of the physical differentiations you might see in a young child with fetal alcohol syndrome. Again, seeing that low nasal bridge, the thin upper lip, the more indistinct philtrum. And this would then correlate also with changes in brain structure. And then we would also see in our clinics or, social settings, school settings, other places, challenges possibly with learning, neurodevelopment, perhaps intellectual disabilities. If we look more specifically at neurocognition and cognitive functioning, the findings kind of show that in the intelligence domain, it's not unusual for IQ scores to generally fall between 65 to 72. So that would be fairly impaired, falling generally more than standard deviations below the normative mean. On the left there, I've presented several other cognitive domains that we commonly assess kids for during evaluations and are critical for learning. So things such as attention, speech and language, memory, processing speed, motor, and then of course, emotional behavioral functioning. Just to highlight some of these things, because I'm a child psychologist, and I think these are things that we can all appreciate, that children with fetal alcohol syndrome also present with high risk for ADHD. So there's some incidence of 60 to 95% fitting within that criteria. The rate of ADHD is 3 to 9 times higher than children without it that we might see in the community. And with that, then you can, of course, see a range of cognitive deficits, such as involving the executive function system, disinhibition, um, because of possibly some of the craniofacial abnormalities. There can be poor oral motor functioning, and this can affect different aspects of the language system. You can also see maybe in preschool or school age, older children, challenges with memory and acquiring new information. And that, of course, is always usually confounded by inattention and distractibility. Other things you might see are just weak processing speed, fine motor skills, and some of the common correlates, of course, with ADHD would just be possibly more disruptiveness, aggressive behavior, internalizing challenges, as well as social delays. There's been some recent literature that I wanted to highlight, looking specifically at executive functioning and social deficits. So these individuals, Rockhold et al., examined both preschool and adolescent groups who had been prenatally exposed to alcohol. And the findings were that there was an association between executive functioning and social functioning in the adolescents, but not the preschool group. However, when this research group did a 4-year follow-up study, that group that was previously the preschool group now also had social challenges. And so these authors were suggesting that perhaps there are also like sensitive periods of social development, just like there would be sensitive periods of brain and executive function development or for other cognitive systems. And so when thinking about like how do we work with children, how do we intervene, and how do we improve programming, their suggestion was, could there also be social skills components built into other interventions, specifically looking at like executive functioning and treatments for ADHD and so forth. There's a large group from University of Minnesota, Dr. Wozniak's team. He is definitely a specialist in sort of the cognitive underpinnings of fetal alcohol syndrome. And so if this is especially an area of interest to you, I would recommend looking at his team's work. Others have shown from a paper in 2022 that youth from 5 to 18 years of age had weaker executive function, social, neurobehavioral functioning. So this would be like having a hard time paying attention, staying on task, keeping track of belongings, right? But also adaptive functioning, which I think sometimes gets lost in the mix of cognitive skills and constructs to kind of keep track of. They're also very important, right? They're factors that really drive independence. And they were finding a specific association between different aspects of executive functioning and adaptive functioning. And so also, not only could social factors be used to improve executive function and so forth, but could this also relate to strengthening a kid's independence? So I think if we take a step back from some of this work, what we're seeing is like a shift away from just this is weak, this is high, this is low, this is high, this is medium, to these things are really hanging together. And even if a child does have kind of a weak area in a cognitive system, it can impact other factors such as their daily living, right? Their participation in everyday activities, which are clinically the things kind of we see in the field and in our clinics. So that was alcohol. Let's now go look at cocaine for a second, right? And I'm presenting this way because one, that's kind of how the research binds it together. But of the prenatal substances, these are some of the ones that have the most research around them and tend to be most isolated from populations where there's a high level of polysubstance use, right? And so specifically, we know that cocaine can act as a powerful central nervous system stimulant. It blocks the reuptake of monoamines, such as dopamine, serotonin, norepinephrine, so all these neurotransmitters. It also happens during critical periods of brain development and fetal development. So again, thinking back to that, one of those first pictures I showed you. And when taken during pregnancy, it can diffuse through the placenta into fetal circulation. It can actually cross the blood-brain barrier and alter things such as metabolism, cerebral blood supply, neuronal volume, other things as well. There has been work that I tried to summarize here, looking at, what are some of the common findings you'll see on the left in infancy, school age, and adolescence for children or youth who have been prenatally exposed to cocaine primarily, right? And so in infancy, there's been work showing that there's slow auditory brainstem responses from EEG, and that heavy use has been associated with intracranial hemorrhaging, specifically kind of more on the heavy side of usage. At school age, there's neurobiological research showing actually smaller sizes in the corpus callosum. There being less gray matter, kind of the core components of the brain in the occipital and parietal areas, a smaller cerebellum, and then you can see at adolescence overall a smaller head circumference, smaller total brain and gray matter volume. There's been indication from structural imaging of there being reduced frontal and orbital frontal volume. So this would be really important to kind of the frontal lobe system development. And then more specifically, there's been pretty clear indication of impaired prefrontal limbic circuit involvement. And so this really is pointing all arrows to a compromised frontal system, which we know is heavily involved in things like paying attention, regulating impulses, being constantly on the go, kind of thinking before doing, all these things that families tell us and that we can often very clearly observe in our work. There has been a group that published this paper in 2014 where they looked at infants, right? And they did brain MRI scans on infants who were 5 weeks of age who had been prenatally exposed. And there were 3 groups there. So you'll see like to cocaine, to other substances, but not cocaine, and then not exposed. And so for the prenatally exposed infant only group, they did find significantly less gray matter volume in those important prefrontal and frontal regions, that there was greater cerebrospinal fluid in several brain regions, which is not a good thing, right? And that there was specific involvement for the dorsolateral prefrontal cortex, which we know is heavily involved in things like working memory, executive functioning. Others have looked at this as well, and this particular group with Richardson looked at infants at 14 months of age, and you'll see sort of the demographics of the population, largely low income, and they found that at birth, the prenatally exposed infants were smaller, had poor kind of autonomic stability, weaker motor functioning. The ones that had exposure specifically, again, thinking back to that initial chart, had poor maladaptive behavior in the first and second trimesters. And then in the later on, those kids had more increased behavioral and temperament problems. So things like being more fussy or difficult to console. And some of the protective factors that they found, which I think is so important for us to think about, right? Like what could actually help in these situations. So protective factors were having multiple caregivers in the home. So maybe a balance of parenting roles, and then having a really stimulating and enriching environment. And those were protective against some of these risk factors that they found. If you look then at preschool and school age, so beyond just infancy, kids who were in preschool who had been prenatally exposed to cocaine showed lower scores on short-term memory tasks using the Stanford-Binet, and higher scores as rated on the internalizing, externalizing scales of the CBCL, right? So showing more outward, disruptive, aggressive behaviors, as well as mood dysregulation, anxiety, and so forth. And the ones who had, again, looking at the timing and the gradation of the exposure, the earlier the exposure, typically the more fussy and dysregulated the children were. You'll see then at school age some similar findings, but now that we can assess more at school age, you see more things, right? So it starts to be associated to physical growth, multiple domains of cognitive functioning like IQ, academics, language, and these things then become, from a research angle, correlated with things such as poverty, parental education, the quality or the attachment of the caregiver and child, um, things that we often see in our work. So we mentioned kind of a review on alcohol, cocaine, and there's also kind of a concentrated literature on marijuana as well. So there's a brief explanation of where that comes from, THC being the primary psychoactive compound, that we know it to produce changes in like mood, perception, motor coordination, and so forth. And that's not just specific to, that's coming from more of the adult literature. But when they've looked at kids whose caregivers had primarily use marijuana and not other substances in utero, they can see in infants that there's delays in like visual maturation and attentiveness. So some of this is coming from the Bailey scales of infant development assessment, where kids are asked to, track different things. You can see physically more tremors and startles. So you all have probably seen some of those reflexes or heard about them, which can be indicative as a clinical sign of an immature nervous system. You can see exaggerated reflexes and a lot of motor disinhibition as well. So the research would say after alcohol and tobacco, marijuana would be the next most common substance use. So probably 3% of pregnancies. And heavy, this is where it starts to correlate, right? So heavy marijuana use is then also associated with higher use of alcohol and tobacco. And so some of these co-occurring risk factors also are things that show up in the research looking at alcohol, cocaine, and other prenatal substances use, right? So when you use multiple substances, that's a risk factor to child development. Other pieces, socioeconomic status, the maternal mental health. Maternal wellness is so important, and you see it in the literature, especially in the past 15 years, be more documented as a factor. Exposure to violence, and also limited access to medical and social services. Again, here on this slide, I've tried to organize some of the research by domains to make it easier to digest in one slide. So if you look at intelligence, attention, visual, spatial, and sensory motor functioning on the left, some of the common findings on the right, you'll see variable and lower IQ generally. You see challenges with attention. I will kind of, release the secret that attention is probably one of the most common things you see across all the exposures. Poor visual memory and visual integration. This seems to be fairly unique, interestingly, to the marijuana exposed population. And then you see also more specific like sensory motor challenges as well. So I'm going to just gently present like a short case example, and then we'll take a planned pause. So we've talked about kind of an introduction. We've reviewed some of the core things about alcohol, exposures prenatally, cocaine, marijuana, and I would love to kind of hear what's digesting, what seems interesting to discuss at this point in the presentation. But first of all, I want to tell you about a 3-year-old that we had in clinic who had been prenatally exposed to cocaine, heroin, tobacco, and details about consumption were unavailable, right? We hear this a lot, so that's not unusual. The child was born full term-ish, so 37 weeks, 7 pounds. There was indication of complicated, respiratory distress. The APGAR scores were low at first, but had improved by 5 minutes. Did stay in the NICU for 5 weeks for cardiopulmonary decompensation, needing, ECMO support. There was indication on the MRI from a left hemisphere hemorrhage, so something physical that you can see an injury on the MRI, as well as left hemisphere hematoma and mass effects, so meaning that the brain is kind of shifting to the right. So this would mean that there's indication of left hemisphere brain injury from early imaging. The 3-year-old was in the biological mother's care for the first 8 months with substances expected that persisted in that time period. And then our colleagues in DCS had gotten involved. For the milestones, the child had walked independently at 10 months, made vowel consonant combinations at 18. So you saw some of the, combinations like ba, 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 and had been involved in First Steps and Head Start in Missouri. So this family had been sort of transient across different states. The kid was inattentive, right? We could have guessed that one. Constantly in motion, on the go, very strong-willed, reactive, aggressive, lots of tantrums, showing off in clinic with lots of tantrums. And unfortunately, a lot of these behaviors were keeping the kid out of the early preschool setting. From a early learning standpoint, the kid was reliably pointing to certain things, but not other colors, knew some parts of the ABCs, but not the whole thing, had a hard time following commands, did show a lot of clear social interests, and came across as very strong in physical play activities, which maybe is not a great thing, right? So kind of overcompensating in play and maybe some of that aggressiveness and temperament kind of showing out, creating some, non-optimal peer relations. But also enjoyed helping out, right? Finding his shoes, picking out clothes, that kind of fun child stuff. So these are just some of the scores. Some of you all may be used to looking at some of these scores. So when you see SS, those are standard scores. They have a mean of 100, a standard deviation of 15, okay? So anything from 85 to 115 for an SS would be typical. There's also scaled scores. Those are SCS. Those have a mean of 10 and a standard deviation of 3. So 7 to 13 would be typical. So you see kind of overall below average intellectual abilities. You see difficulty recalling sentences, so understanding things and then repeating it back. Some challenges specifically with vocabulary and language systems as well. We found that the right hand was also very weak compared to the left hand. The Bracken is a measure that looks at school readiness. This was also quite low. Over here on the BASC, which is a parent rating scale, the T-scores represent a mean of 50, a standard deviation of 10. So the higher the score, is more concerning. So things in this 70 and above, I would say, are more clinical. So the parent was reporting challenges with hyperactivity, aggression, anger management, executive functioning, those kind of things. You'll also see on the left there the ABAS, which is a measure of adaptive functioning, kind of overall just being at the within normal limits range, except for some challenges in kind of that more problem-solving conceptual domain, which logically kind of hangs together with what we gathered from IQ and pre-academic skills. So on this little 3.5-year-old, we found relatively intact visual motor skills, a left hand that seemed to be functioning appropriately for the task at hand, having clear social interests, and then some of the adaptive functions were intact. However, there were really significant challenges with attention, the language system, the right hand, and a lot of challenges associated with behavioral regulation. So tantrums, aggression, limit testing, that kind of stuff. From kind of my lens, there were a number of risk factors, right? ADHD, the kid's only 3, I recognize that, but that's certainly a risk factor. Language and learning disorders, certainly a risk factor coming down the pipeline. Behavioral and emotional disorders, we're catching early symptoms of all those things. And some of these had broad explanations, right? We know that from the review that prenatal exposures can be associated with things like inattention, behavioral and emotional dysregulation. And then from a neuropsych standpoint, there's also some indication of early lateralization as well. So this patient had quite notable left hemisphere brain injury. And we know that those things are contralateral in the brain. And so we were seeing that in the fine motor systems. For this patient, at the time, we had recommended, of course, an IEP in special education, preschooling with underdevelopmental delay, with a range of services that we encourage the IEP team and case workers to consider, such as speech and language, occupational, physical therapies, a very positively oriented behavioral intervention plan. So things that's really built on praise with the goal of keeping the kid in the class, and a strong focus on pre-academic skills. Parent-child interaction therapy, again, another gold standard parenting intervention was recommended. it's hard to find in certain communities, but if that could be modeled at the very least in a school setting or given in an abbreviated format, that was suggested. Encouraging a lot of educational activities at home, and then clear follow-up within a year for close monitoring of what we suspect will be ADHD and other behavioral disorders. Okay, so I'm going to do one of those planned pauses now, and I would love to know if people have questions. You're welcome to throw it out there. There are many of us on here, which is great. And if Carissa, Caleb, and Kevin can maybe check out the chat, if anything.
Oh, you have so many questions, Mr.
Okay,
Molnar,
great.
in
Well,
here.
we might
I'm
need to
gonna
part
go
two on this.
a little bit in reverse order because we're most recently talking about it, and we'll get back to some of the alcohol exposure ones. But one of the more recent ones is that you were talking about the co-occurring risk factors that were there. And so Maura had the question kind of around that piece, saying if some of the protective factors include the environment children are raised in, how do we know that things like executive function or emotion dysregulation are caused by prenatal exposure to drugs, as opposed to being a result of growing up in a home with parents with addiction?
Yeah, I think it's a fantastic question. And I think I'd have to kind of put the caveat, and a lot of these are coming off of research studies that are, more controlled. And to be honest with you, I don't have an excellent answer to that question. I think it's super complicated. I think the idea from the researchers would be, are there ways to build out some of those protective factors so that they may play against some of the known risk factors related to the exposures alone? But if anyone else has thoughts on that.
No, I mean, I think that that is something when you different research studies that I've looked at do try to account for that in different ways. And you're kind of synthesizing some of the research on there of looking at what do we know in the environment and how are we looking at that, which is that challenge of some of these more with research restrictive studies, the applicability then to some of the populations where then you do have confounding factors as a part of this life for kids, especially with our custodial kids, where we know that there's concerns for this exposure that hasn't been clearly documented or has been in different ways, on top of kind of the sequelae of impacts from different forms of adverse experiences in homes and
Sure.
in their lives. It's a challenge.
I mean, I think one to that point, yes, and I think it's a great question that was posed. I think the one point is I think we can speak confidently, whether we're in court systems or we're in team meetings and so forth, we can speak confidently knowing that there is a risk factor right there alone with prenatal exposures, right? And so these other factors are certainly mitigating. So, of course, having a strong, secure attachment is desirable. Of course, kind of a more advantageous living environment, having a more resourceful setting where the caregivers are mentally healthy and so forth are factors that are important, right? But, if you're in a setting where you're asked to make a statement about prenatal exposures, I think it's fair to say, with the wealth of research in this area, that yes, there are clear risk factors, right? There are clear mechanisms here that can be causal and affect neurocognitive development.
That's so helpful to clarify that of what we know for them. Thank you. During the discussion and in your slides on some of the studies with cocaine exposure, one of the protective factors that you noted was a stimulating environment in the home. And the question was, can you elaborate on how to promote a stimulating environment?
Absolutely. Another great question. So I think learning activities, right? Books, availability of books, having structured times to read, structured times to do certain learning activities in the home environment, whether it's modeling certain chores or modeling certain lessons, making the home environment as transactional as possible. I think are things that are important. I'm not sure how those researchers in that study would define it, but when we think of like an active living environment, something that is dynamic, intentional, it includes a lot of supplemental learning activities.
Kind of that enriched caregiving environment with the attunement to what that child needs, lots of opportunities.
And that's going to look differently across homes, of course, right? And it's going to depend upon a lot of other resources and factors. But turning household activities into play activities, or having really intentional times where we're doing different things that are shared experiences between caregivers and child, or siblings and child.
Coming back a little bit to some of the fetal alcohol syndrome questions, and we got some more as we've been talking coming in too. Two questions here. Does fetal alcohol syndrome affect life expectancy? And does fetal alcohol syndrome diagnosis preclude an assessment for autism?
For the life expectancy one, I would think at the more severe levels, that because of the cardiac risk factors, that there could be an association with life expectancy long term, right? At the more mild end, I am not sure, to be honest with you. But I would think at kind of that more moderate, especially severe range, where we suspected heavy chronic consumption over the course of prenatal development and early on in infancy and early on in childhood development, you see very distinct physical features that are mapping onto what we know about the sequela of fetal alcohol syndrome. Yes, for that kind of core component, I would think that there is a effect on, long term.
Yeah.
And can you
This
repeat
question,
that second one? I'm sorry.
yeah, no. Does fetal alcohol syndrome diagnosis preclude an assessment for autism?
I don't think so. No, I would not. Does it?
I wonder with this question, I read that with preclude as like, does it prevent an assessment for autism, or does it need to go before an assessment for autism? I'm not sure.
I've not
Jennifer,
heard
you
that.
want to?
So I don't know if it's necessary if it comes before or after. I also haven't seen, I mean, this is going to open up a whole nother set of questions, but there still isn't a strong association between fetal alcohol syndrome and autism specifically. It doesn't mean it can't exist, right? But it's not driven in like these large populations that are being studied. I don't see it as being required to
Dr.
have
Molnar.
autism workup. Yes, please.
Sorry, this is Jennifer. Preclude may have been the incorrect term, but I have not seen a lot of autism diagnosis or assessment in folks that have fetal alcohol syndrome diagnoses. And so I didn't know if in your experience, that autism isn't even looked at necessarily if you
Got it.
already have an FAS or FASD diagnosis.
I understand. Thank you for clarifying that. I appreciate it. Yes. To the point, like I haven't seen a lot of when we think about like the cognitive functions and the social components and the neurobehavioral pieces, it's not standing out in the literature yet as being something that's strongly indicated as there being a more specific link between the alcohol exposure and autism. So I don't see that in the literature. I don't know if it's being missed. I can't speak to all the researchers that do that line of work. Certainly, a kid can have prenatal alcohol exposure and also have autism, because we know autism also carries its whole other set of specific risk factors, right? Many of which are genetic. So I don't want to say that can't happen together. Of course, it can happen together. I haven't seen it as like a strong pattern, though, in the research. Thank
Another
you.
assessment related question. At what age can a child begin being assessed for fetal alcohol syndrome?
So I think that's going to require the coordination with pediatricians and early access to both medical care, developmental pediatricians, and all of our teams, kind of involving psychology and social work teams and so forth. I would say that we know these features are distinct, right, early on. So in the right care of expertise, I would say it's fair to expect an early diagnosis and early identification. And then with that first diagnosis, then comes all the correlates that unfold with age, right? So from infancy to preschool to school age, et cetera. But my understanding is that this can be physically kind of distinct from a very early stage in early childhood.
Okay, a couple more have come in while
Yep.
we've been talking. One is for fathers. So if a father was using drugs or alcohol during the time of conception, and the pregnant mother had not used any substances during conception, is there any detrimental effect to the fetus from the father?
I cannot speak to that. I don't know.
That's
Yeah,
I hadn't
it's a
thought that's a
great
good
question.
question.
Y'all are
I'm gonna have
tough.
to dive into that. See if I
Yeah,
can get that.
that is, I hate to blame everything on the literature, but that's how we learn things, right? Um, you often see in these studies, studies focused on maternal health and maternal factors. I have not reviewed a paper where paternal factors are captured. So I can't imagine it not having some association, but I wouldn't think it's as pronounced as the maternal consumption of alcohol where it actually
It's a
infiltrates.
cross development. Okay.
Yes.
Some conversation in the chat around services and accessing services, but then also this piece of um, documentation and when to access services. So Carrie here in the last one had noted that since some of these difficulties don't show up until toddler age, what would be the best practice for encouraging caregivers to seek early treatment? We typically get our clients as babies, and we hear from caregivers that there are not concerns during infancy, and it kind of emerges later as a toddler. So what's the best practice for encouraging caregivers to seek early treatment?
Yeah, I think this comes up in the neonatal abstinence syndrome group as well, because sometimes we don't see, we don't see kind of the full play out of things yet because kids are young. Constant surveillance. I mean, consistent surveillance to me is like the logical mechanism, right, to catch these things over time. And so gaps in surveillance. So when a kid is 2 and then 6 and then 12, like that's too wide, right? But like almost like we have annual well checks, right? Like these kids that are at high risk because these prenatal exposures almost need like a unique well check to monitor for these neurocognitive factors.
I think a lot of time, part of what comes to mind for me with this is that tracking over time. And so for some of our services and points of contact with families and children, it is maybe that toddler, that late infancy, and that role of early intervention screening to get at those domains of development and monitoring. Like, are they behind with their fine motor, their gross motor, their speech, as some of those kind of active monitoring pieces when we're trying to get information when we haven't had information for a little bit of time, and that monitoring.
Yes. And Dr. Smith, I'm probably going to put a pause there on the questions and continue because neonatal abstinence syndrome is part of the title. I want to also get
That
there
sounds
as
good.
well. And we'll do a pause at the end, of course. And then we're always happy to follow up over email and stuff. But these are excellent questions. So thank you all for being here and participating. I want to mention environmental toxicants as well. So things we think about as being mercury, inorganic lead, the PCBs. These can also be a unique set of environmental exposures. So mercury, for example, being a natural element, it's commonly found in things like pesticides, cosmetics, dental fillings, other things. And it can be ingested, inhaled, absorbed, and so forth. And we know that the dimethylmercury is kind of the more deadly mercury compound because it can permeate the skin and get into the bloodstream. There are ways to sort of measure this, and the U.S. Environmental Protection Agency kind of suggests kind of a certain level. But we know from research that approximately 8% of women who are pregnant have mercury concentrations greater than that level. So you do see maybe sort of more of a dose linear response relationship that is harder to maybe detect when things are just kind of reported by self-report. So we can actually kind of measure the levels. They do find that there is a gradation in terms of severity. Fetuses are especially at high risk because they have an inability to excrete this mercury. So at the higher levels, you can see things such as cortical degenerative disease, CP, intellectual disabilities. Again, with the common theme across all these substances being when it's more severe, you're probably going to have likely more effects because it's involving more systems in the body. For the PCBs, this is part of human-made organic chemicals. So prior to the 1980s, I'm not going to ask anyone to raise their hand if they were around then, but things that were found in transformers, adhesives, tapes, certain rubber products, and these also have been known to show like a dose-dependent relationship between PCB and neurodevelopmental outcomes. There is unfortunately not necessarily a profile. That's probably because it's harder to maybe isolate a population to study, but there have been some suggestions about associations with birth weight, sensory motor functions, and then verbal and executive skills. One that has certainly in the past 15, 20 years gotten a lot of attention is an organic lead. So common environmental metal, it's a known neurotoxin. And this primary route of exposure has been through maternal occupation, interestingly. So similar to other substances, it passes the blood-brain barrier and accumulates in fetal organs. So again, kind of having more of a direct association between the mother carrying the child and the fetus. In children, the dopamine system, which we know, again, is a neurotransmitter that has implications for things like ADHD, is especially involved, and there's associations with different aspects of the prefrontal cortex. I'm hoping you're seeing that across these substances that the frontal system is a vulnerable system. Not only is it take the longest to develop and grow, right, into the early 20s, it is very commonly implicated in a lot of these more specific populations of prenatal substance exposures. Overall, for lead, the incidence rates have declined, thankfully, but that's not true necessarily in low-income areas for families that reside in older homes, and then for families that are from racial ethnic minority communities. There is kind of a interesting kind of more dose response relationship, as I mentioned, between blood level and neurocognitive outcomes. And this isn't maybe something that's unique to this population. So the CDC has also gotten involved and kind of set their threshold. We know that with toxicity, it can be associated with headache, irritability, physically things like vomiting, weight loss. Research is showing cognitively things like inattention, executive dysfunction, poor visual spatial functioning, and then some of these other similar neurobehavioral symptoms that we've seen in other populations, such as like cocaine exposures, such as restlessness, aggressiveness. There is indication that chelation therapy is an effective treatment at reducing lead levels, but it is not necessarily protective against the neurocognitive deficits. I think that's, a take-home message there, is thinking that like that therapy can treat the lead level itself, but it doesn't necessarily, again, protect against the development of cognitive challenges in youth. How is this relevant? Well, let's think back to maybe over a decade ago, the Flint crisis, right, in Michigan. This was kind of definitely something that took over the news. It was devastating and continues to be devastating to communities. And it happened right here in, the modern United States. There was notification in November 2011 about it, landing as sort of a crisis. All the way, you'll follow this timeline if you're interested in it. And a lot of this information is available on the CDC, as well as separate universities like Northwestern, and had gone through several cycles where it eventually, in 2016, has presidential endorsement as sort of a state of emergency. If you're like me, we tend to kind of cycle through and sometimes forget about things. And sometimes it's not until there's more political fire or news development about something that it might trigger our mind. And this is the case here also with Flint as well. So even though it's something that had triggered back in 2011 and took some time to get some action about, the process is still being addressed. So for preparation for this talk, I went back and did some research looking at, what's happening now. And there is a massive settlement that's being available. And this settlement was sort of, approved by a judge in 2022. And there's approximately 25,000 individuals that qualified, many of which are children who were children at the time of exposures, but there have been delays in the system. And even as of now, like this month, 2025, there's a notification on the government website that payments are supposed to be distributed. So just showing kind of the timeline of how some of these factors that we know are physical and health risks and have associations to learning and cognitive functions still aren't settled and are still an influx to many children and families. If you're interested in this, I went ahead and put sort of like the michiganpublic.org website. It's very interesting to follow and is an easy way for someone like me to completely get off the railroad track and go down a rabbit hole. But it's a great example of public health and how a lot of the things that we see are intersected with that very closely. The American Academy of Pediatrics have provided this information back in 2016, noting that about 2.6% of children below 5 were exposed to unhealthy levels of lead, and that the prevention was really to identify and eliminate the sources. And some of their recommendations really fell to things like, collaborating with elected officials, really supporting vulnerable communities, encouraging housing assessments for homes that are built prior to 1960, testing blood concentration levels. So again, surveillance being really important, and really having extra care for what we know to be more low-income communities. Okay, so we have about 30 minutes left, and I'm going to focus for the rest of the presentation on neonatal abstinence syndrome, which I think is particularly relevant not only in the country, but also in our state of Tennessee. And it's something that I know you all encounter in your own specializations. So NAS refers to challenges newborns have when withdrawing from prenatal exposure to addictive substances. So this can include things like heroin, other opioids, hydrocodone, morphine, tramadol, other prescriptions like antidepressants, benzos, and the symptoms often onset 1 to 10 days following birth. And so this classically involves trembling, a very distinct, like high-pitched crying or shrill, the infant having difficulty calming when consoled, having very tight muscle tone, very hyperactive reflexes. There can also be increased risk for seizures, poor autonomic temperature control, having difficulty breathing, poor feeding, poor weight gain. There's a lot of work in our NICUs across the state, especially in Northeast Tennessee regions, with these young children. NALS, you'll see neonatal opioid withdrawal syndrome, is more of a recent term that is really referring to a type of NAS and specifically withdrawal from opioids. And this is really reflective of the rise of the opioid use in crisis. This can include things like legally prescribed opioids, also medication for adults with opioid use disorder or other illicit drugs. And it has a pattern between the two of similar withdrawal symptoms, but refers to different underlying causal substances. So I put together this chart for you all, looking on the far left at definition, cause, relationship, symptoms, terminology. In the middle, you'll see NAS. On the far right, you'll see NALS. And you'll see in the NALS column, I've highlighted in bold some specific things to key into, meaning that NALS is like more specific term. It's referring to withdrawal of opioids only. It's caused by opioids. And it can involve those things like excessive crying, shrilling, rapid breathing at birth, kind of really jolting tremors. And this term seems to be more representative of the current opioid crisis. Interestingly, Tennessee was the first state to require reporting of NAS for public surveillance. So it is written to be reported within 30 days of a diagnosis. Generally, this is done more often than not by the birth hospital. However, there's been reports of about 12% of this happening at the transfer hospitals, but by and large at the birth hospital. When we think about current trends, I think it's important to look at like historical trends as well. This information comes from the Tennessee government website. And so if we go back to like 1999, you'll see a bar graph here. So on the y-axis, you'll see the number, right? And over time, on the x-axis, you'll see the years. And so you'll see this kind of over time steady and then sharp increase by 2010 and the rise of the incidence. The Tennessee Department of Health, you can find this on their website. It is very helpful. It is downloadable. Our colleagues, if any of them are on here, did a fantastic job putting this together. It's readable. It has great information in it. It's capturing data from 2022. It was published in 2024, and it is a neonatal abstinence syndrome report from the state of Tennessee from 2022 that was, available in 2024. Noting that in 2022, there were 797 cases reported to the Department of Health. The incidence was 9.8 per 1,000 live births, with the highest rates being in East Tennessee and Northeast Tennessee. 86 were white, non-Hispanic white women. 84% had TennCare. 66 reported smoking during pregnancy. 53% reported having inadequate prenatal care, with 38% of that group, the 53%, having no prenatal care, which is heartbreaking and alarming to me. So that 9.8 incidence in Tennessee is compared to 6.3 incidents nationally, noting that it's a significant and continues to be a significant problem here in our state. You also see, this is just a way to depict it. So you think nationally, so the dark blue areas are more concentrated areas where the rates are higher, all the way going down to more the gray areas where it's less prevalent. And you'll see kind of Tennessee, more southern states clearly being kind of more notable areas. And then from the Department of Health report that I was describing, they included this very helpful picture here showing the state. Again, the darker areas being where the incidence is higher, and you'll certainly see high rates in Shelby County, down in Memphis, southern parts of the state, but then also more notably the Upper Cumberland on up to Northeast Tennessee, Sullivan County, and so forth. So in Tennessee, there's a tenfold increase since year 2000. The trend shows that the increases tend to follow a pattern more strongly from west to east, with Northeast Tennessee being more heavily affected. And in Shelby and Knox counties, the Department of Health notes that the exposure most commonly involves a combination of illicit substances and prescription medications. If we look back at some of the neurodevelopmental literature, it always takes research a little bit to catch up to the change in terminology. So you'll find both NAS and NALS used interchangeably in some of the literature. You don't quite see that full differentiation. So in looking at some of the core risk factors, there is kind of higher risk for cleft lip and cleft palate, physically presenting. And this seems to be something that is especially notable for isolated cleft palate, and that prenatal exposure to opioids may be a specific environmental risk for this condition. In addition, more neurodevelopmentally, there's been indication of hearing loss. This is coming from a study by Rig and Rig in 2020, suggesting association between opioid exposure and hearing loss. And this might be an increased risk for mothers who are military veterans or in really laborious occupations like construction, farming, mining, maybe where it's really physically demanding. And so there's a lot of substances being used to kind of control pain, also in maybe low socioeconomic or rural populations. Opioid exposure, they point out, may be associated with actual involvement of the auditory pathway from a physiological standpoint. And some of their recommendations were, when we're working with these families, really try to inquire about maternal opioid use in the case history review, ask about any medications that may have used to treat physical pain or opioid use disorders. And then, of course, utilizing non-confrontational, non-judgmental language and avoiding stigmatizing terms to really kind of help decipher and get information about what we know to be the history of the child, so forth. Other things that are showing up in the neurodevelopmental literature in this area, researchers have looked at infants with NAS and assessment 9 to 12 and then 15 to 18 months. And they found that there were early indication of at 15 to 18 months of children showing weaknesses on the cognitive, language, and motor sections of the Bailey. So again, if we think about early detection for our friends that are kind of in that NICU discharge and TEIS follow-up areas, even at that young of an age, they're already seen on the Bailey those core cognitive kind of domains being implicated. This line of researchers, Benninger et al., also has used kind of this research to look at different characteristics as the patients are aging. So by 2 years of age, they found that the cohort that was studied was being referred for speech and language therapy, and that these were kids who were specifically at risk for language and motor domains being impaired. At Vanderbilt, we've done some research, myself and Dr. Autumn Kojawa and Catherine Humphreys at the university in the Peabody School. A lot of this came out of the pandemic, where we were kind of thinking about what can we do now at home with our teams and so forth. And we decided to kind of start looking at some of this work, where we were examining sort of the relationship between opioid exposure prenatally, postnatal adversity, and then cognitive functioning. What we found in a sample of preschool age kids who had been prenatally exposed was that the children prenatally exposed had lower intellectual functioning scores, including in verbal and visual reasoning domains, lower working memory scores, and lower processing speed. So this was showing up on the WIPSI, which we would know as one of the Wechsler scales that's used to assess cognition in preschoolers. And that these children also had greater exposure at some point to postnatal adversity. So things like abuse, neglect, spanking. And this, interestingly, this effect, this association disappeared statistically when adoption status was controlled, suggesting to us that, adoption, again, the importance of a nurturing family environment may be a protective factor against some of these challenges. We found that the opioid exposure alone accounted for 6% of the variance in cognitive functioning, which doesn't sound like a lot, but is statistically quite significant, suggesting that, again, similar to other substances like alcohol, cocaine, the opioid exposure alone can be a neurobiological specific risk factor. When some have looked at school age, so not preschool age youth, they have asked teachers and caregivers to complete the CBCL. So you'll see this in a lot of your work. Some of you all may review it as part of casework and so forth. So it's a parent-teacher rating inventory. Both caregivers and teachers received it. And you'll see that there was a lot of similarity in how caregivers and teachers rated children who had NAS or NALS. And that was specifically true for a lot of the externalizing symptoms, so things like aggressiveness and dysregulation. They're noting social problems, challenges with attention regulation, and then being at very, very high risk for ADHD. That was a very clear, highly significant, consistent finding between both teachers and caregivers. And then there's been also some work from this group by Phil et al. From 2018 showing that children with NAS are more likely than typically developing children to be referred for a disability evaluation at some point by school age, to meet criteria for a disability, and to need classroom services and therapies. So You already see some of these emerging factors related to neurodevelopment. There has, at a basic sciences level, been clear brain associations that have been made, linking it to overall brain and gray matter development. So these are things that also have been implicated in other populations that we previously reviewed. You can see microstructural changes and white matter integrity, which we know is really important for the transmission of information in the brain. And there's specific involvement from what was called like the cortical striatal thalamocortical networks, which have implications for the frontal lobe. And again, the frontal lobe continuously comes up in this population of prenatal exposures as being implicated and having a likely association. This research group that we worked with, some of my colleagues at Vanderbilt, we found that the preschoolers showed significant signs at preschool age of inattention, defiance, aggressiveness, as well as anxiety. And we also used what's called imaging, so event-related potentials, which are meant to record different aspects of brain waves live time. And we found that kids with prenatal exposures to opioids actually were they perform more poorly on these tasks, especially on tasks that were really important for them paying attention and kind of regulating strong responses. One of the projects that we've done with this preschool age group, now that we've seen not only cognitive, but also some brain implications, is we wanted to know if interventions are working, right? So my colleagues and I, we received a Vanderbilt Discovery Grant several years ago. And because of these ratings of significant ADHD signs and inattention and impulsivity in these young kids, we wanted to know if a modified version of PCIT, brief behavioral intervention, could be used effectively in this population. So again, training parents and caregivers to modify their approaches to parenting to really increase compliance and decrease more maladaptive symptoms. We did find that this approach, again, it's a published kind of modified version of PCIT, was effective. We saw reductions in a lot of these current symptoms. The paper is currently under review, so I don't want to sing its praises too much, but it will hopefully be available probably within the next 6 months. But it's hopefully linking also, not only are we seeing patterns, are we seeing brain involvement, are we seeing cognitive implications, but we're also seeing that like some of the parent-directed interventions that are known to work with other clinical populations are showing promising signs here as well. We know that this is an important area of research, right? Again, especially in our state, 10K reports that infants with NAS will require 5.8 times more healthcare costs. They're more likely, much more likely, as you all very well know, are likely to enter state custody. And that many of the hospitals, especially in Northeast Tennessee, are consumed by this being something that fills their patient volumes. This also garners a lot of political attention. I'll let you kind of, due to time, kind of read up on this on your own. But if you recall back to several years ago, in 2014, where the Tennessee fetal assault law had been put into place, thankfully, there was a sunset clause written into it. So it expired in 2016 naturally, but just showing how quickly things can take a really dangerous direction. And this did unfortunately negatively affect about over 100 women in the legal system. But it came to a quick rise because of the epidemic, and it got implemented and approved. It is no longer in existence. But with our vulnerable populations, including the family systems, things can happen that really strengthen the stigmatization, which is what we don't want, right? So there's a social policy report that's been published, really encouraging people to take non-punitive approaches to intervention, helping improve access to care. I know that gets hit over our heads many times in many different directions, but it's so important. Finding ways to help improve the patient to provider relations, thinking about prevention strategies as opposed to consequences. Again, improving prenatal care access, going back to that statistic that so many women reported not having any prenatal care at all. incorporating substance use screening into prenatal visits, and then of course additional funding, which I know is challenging at this time. There's other things here that the report recommends, during pre-pregnancy and during prenatal screenings. I have found value in the findhelpnowtennessee.org website. So it's here, and all these slides will be available as well at the end of the presentation. We talked earlier from one of the questions about surveillance. That's one of the recommendations coming from the policy report, is that this population especially be surveyed very closely because of not only the immediate, more neonatal risk factors, but the high rate of likely ADHD and other neurocognitive and neurodevelopmental implications. And there's going to continue to be, not only with this population, but with all of our populations, and this came up in a previous question, challenges associated with bridging our programs, right? Going from NICU to TEIS to Head Start into other school programming pathways. We want to do our best to narrow those program gaps so that families are making transitions as easily as possible. You all know this kind of work, what some of the recommendations are for early interventions, especially in preschool programming settings, and the types of services. Like I've mentioned, it's really helpful to survey, to advocate. There's a high risk for ADHD in this population specifically that takes on more like moderate to severe qualities that we'll want to kind of pay attention to, not only in our clinical work and in the research. And this is probably my favorite slide, which is why I'm going to end on it, because it doesn't have anything to do with the research, but it comes from parents. When you just ask parents, like, what would you tell other parents, that have children with opioid exposures? What do you recommend as a parent parenting a child? And parents have said, get yourself a pair of earplugs. One parent told me the shrill is real, and I'll never forget that. Do not feel bad about wearing you will still hear your child, I promise you. Using things like a dimly lit room, not having a lot of stimulus around, using a quiet voice in the home, engaging in a lot of sensory activities. I've been told, like playing animal crawls or having like safe deep pressure activities, or even like pushing heavy laundry baskets just to get some energy out when maybe the kids who are 3, 4, and 5. Parents have told me about the importance of diet, that there have also been challenges with things such as constipation, really linking in developmental pediatricians and psychosocial network providers. When feasible, because of the risk for ADHD, considering discussions about medication at appropriate ages. Parents have described unique dental issues, some of which the providers may not be aware of, because this is such an emerging area of research. And also taking the time and opportunity to explain to therapists and caregivers and providers and anyone that is involved in the care of patients the likely associations between prenatal exposure, such as opioids, and brain development and neurodevelopmental functioning. And that's my favorite slide. What I will leave you all with, if we think back to the very first couple slides, is that we know that prenatal exposures, regardless of what they are associated with neurobiological, neurodevelopmental, cognitive, and neurobehavioral challenges. The NAS and NALS has been an epidemic, and especially in our state, and it tends to trend higher in East and Northeast Tennessee regions. It is associated with maternal risks, things that are modifiable, right? Like prenatal care, substance use disorder treatment, other things that are harder to manage, like polysubstance use, different demographics. There is an emergence, this literature is not as old as the cocaine and alcohol exposure literature, because it's more of a recent trend. But there is some work showing that there are specific brain networks involved, that there is an increased risk for what we would call clinically ADHD and other behavioral disorders, and that there are a breadth of resources. Sometimes the coordination is challenging, and from some of our early work, we are seeing that similar to what we know in populations such as like kids with oppositional defiant disorder, ADHD, or other things, that some of the parent-directed interventions that we're savvy with, right, are actually effective for this population as well. And it is 1:26. So.
I have to hand it to you, Dr. Molnar. I did not think you'd get through all those slides, and you managed to get through them.
I
That's
don't like
impressive.
to cut people off, but when you all these great questions at the midpoint, I was like, whoa, we
No, you needed to. That was well done. I do want to go through kind of housekeeping, and maybe if we have time there's some discussion around in the chat that you mentioned adoption kind of takes away that significance that you're seeing. One, Karen wonderfully dropped the link. So if you'd like a certificate of attendance today, complete the survey. Even if you don't want the certificate, if you could complete the survey, give us feedback. We love all the recommendations for additional trainings and thoughts and feedback on how this went. So that is in the chat. If you could take that, and if there's any issues, let us know in the chat if you click the link and encounter any issues with that. But complete the survey to get your certificate for attendance today. I know many will have to hop off, and I know Dr. Molnar, we want to be respectful of your time too. I think one of the questions I saw pop up here was, I kind of lost track of it in all of this. Here, was looking at the slide that you mentioned with the cognitive impact. And when you were doing the study and you were looking at adoption, you saw that significance in decline in cognitive impact disappear. For that, there were some questions around, could you say a little bit more about what you specifically saw with that? And does it generalize outside of that study and the research?
I don't know that, but it's again, we think about how dynamic things, right, are in that last slide, talking about the neurobiology, the neurodevelopment, the social stuff. All these things are like it's like a lasagna, right? It's just like stacked. And so we're looking at these different pieces. We found that, so I have to speak to that question from like a statistical and research standpoint, not a practical clinical standpoint. So when we controlled for in the statistical model adverse environmental effects or associations or correlates, the overall neurodevelopmental risks decreased for that population, showing that like the adoption process may be like a mediating part of promoting kind of a healthy, secure environment. That's what can be garnered from it from like a scientific standpoint, right? There still did seem to be a unique, that's why I talked about the 6% of variance, which is a lot in statistics. Variance was accounted for in like the kids' intellectual functioning, but there's a lot of other variance that wasn't accounted for. And so when we controlled for those possible other stressful circumstances, the effects were thankfully not as pronounced, which means that the quality of the environment has an important role. We're seeing that from like a statistical lens.
Yeah, that kind of stimulating environment, enriched caregiving environment that you're noting there.
And it was strong enough to measure it and to capture it in a statistical model, which I know is very researchy, but it has a lot of like practical influence. So when you're talking to families about like healthy home environments, things like parental caregiver health, like stimulating home environments, settings where there's not a lot of, well, obviously abuse, neglect, like those kind of things, stress, trauma. These are all optimal things for health, right? Those are things we don't want, are those negative things.
Question with that, when you were looking at it, did you look at the timing of the adoption? Like, were these kids that were adopted early on, or just had at some points in the time that you were in the study that they had been adopted?
Unfortunately, some point, just because we were, if we start to chip away too much of the sample, we lose statistical power. So we just getting a initial sample of kids with that NAS and NOWS diagnosis from the medical charts was challenging enough. We would need a much larger sample to start to stratify that.
There was another question in the chat about someone who works a lot with moms who are involved with MAT programs, and just saying that they're working with moms who are seemingly being educated that the MAT programs, if they're on Suboxone or something like that, that's not going to have the same impact. I guess, can you speak to like the status of the research for the impacts of moms with opiates involved in MAT programs and what the education is like for the women in those programs about the impacts on kids?
That is not something that I see clinically. That's definitely outside the scope. I mean, it's a great question, but I would have a hard time speaking to that, to be honest with you. I'm sorry.
Okay.
I don't know if anyone else has any thoughts about that. I don't want to give just like an opinion. I want to make sure it's something that's like referenced to something that's been indicated from the research.
That were born addicted, NAS. As adults, are they more prone to become addicted themselves because they were born with it in their system?
I would say that it's fair to say there's a higher risk. I mean, the cohorts we're looking at, the groups we're looking at now are, you know, school age, tipping into adolescence and so forth. So it's going to take a lot of time to kind of get more of a lifespan implication on this. But I think we know from just broader social science research that things typically follow in family and genetic patterns, right? And so if we know that rates of substance use are certainly heritable, if you will, or they exist in homes within the family, similar family systems. So if it exists in one generation, it can have an association to another generation. So I think it's fair to say that, yes, there's a higher risk of it being a challenge that could come online down the road. Yes. And that's not coming just from opioids alone. That's just looking at like thinking about the substance abuse literature in general.
We do have several questions we weren't able to get to in the chat today. If there is anything that is urgent and pressing on your mind, feel free to speak up now as we wrap up.
And I'm curious about the question that I couldn't answer. I want to actually look into that because I don't know how to pivot to give a sound response to that. It's definitely not something that's in my practice pattern. I don't have experience with, but it's a very relevant question to this population for sure.
Okay. Looks like we're ready to wrap up then. We really appreciate your time today, Dr. Molnar. And I think this parallel between all the complex questions of many different ways that the people on the call are interacting with this topic and kind of the challenges in research, right? Of how do we kind of understand this complex piece and what can we pull out? I'm very thankful that you were able to kind of walk us through what do we know, what can we speak to, what are we learning about this and complex topic, and give us some really helpful kind of anchor points and discussions in our work with families. So thank you.
Absolutely. I hope it was helpful. It's also a learning opportunity for me because I'm not often in the field. And I think there is constantly in any sort of clinical population a balance between like what happens in the community. So often in these populations, there's polysubstance use, but then how do you study it? You need populations that are more kind of uniquely associated, and that presents just sort of a natural challenge to balance. But it's my pleasure being here. Thank you all for setting this up and for hanging in for an hour and a half.
Thank you. We appreciate it. Thanks, everyone.
Bye.